Thank you, George. Next, I would like to invite up for a panel discussion Dr. Cohen, who's going to moderate, as well as Dr. Kalik, Dr. Generou, Dr. Petrosian. You can come on back up when you're ready. Dr. Chung, Dr. DeMeo. I see Dr. Berkey's up here. Thank you.
Well, thanks, Matt, and great job presenting our study.
I have one question for Jaffer. I didn't know they were going to allow 33 TAVI centers in the UK. I thought it was only 2.
They have a few more now. Well, it's been an interesting set of morning presentations, and we have a good group up here to have a wide-ranging discussion. So since we just finished on the embolic protection side of things, let's ask Philippe, first of all, just what are you guys doing in Morristown this year?
Yeah, so first of all, I'm a strong believer of neuroprotection. Okay, I will say that. Unfortunately, I don't know why it doesn't translate into usage of Sentinel in patient. And we use it maybe in 5% of the patient, I would say. But I feel that it's probably just because we didn't have enough compelling data. That being said, I will say that it's maybe because it's not the right device right now. When you look at the stroke, the MRI study in the Sentinel, you look at the image, it's scary both arms. Like one on the left with protection, without protection is terrible, and with protection is like not pretty neither. So I don't know, maybe we need to protect the full brain. Maybe we need a device that does not embolize air when we use it. I don't know. There's something that does not feels right. That being said, I use it when there's a clot in the appendage. I use it when I'm doing Watchman with clot in the appendage. I use it when mitral valve and valve. I use it for all the other reasons, not than the
Every
one.
place has not been studied.
Yes, exactly. Because I truly believe in protecting the brain. That being said, every time I see the data for disabling stroke, I think there's a benefit, but it's a sub-study, so we cannot tell. But the gut feeling is that it's needed, and I'm always torn with my behavior, actually. So.
Dr. DeMeo?
Yeah, I was going to say that in the cardiac surgical literature, stroke prevention is something that's been very difficult to do as well. So, there have been neuroprotective devices that have been used in cardiac surgery. Lots of studies that have looked at everything from transcranial Doppler to postoperative MRI, depending on surgical technique, single clamp, side biting, cross clamp, on pump, off pump. And, the consensus is that we've never been able to really come up with something yet that has been able to make a big difference. And it makes sense that a cerebral protection device would help. It's a tough problem to solve.
Yeah, it is very, very interesting. Will, did you have something you were?
Yeah, I just was wondering if I could get your perspective on the statistical validity of the disabling stroke results. And it's just been a lot of talk since that trial was been presented.
Yeah, I think it's, the statistics are clear. We don't get to sort of because it failed its primary endpoint, we kind of have to stop talking about statistical meaning after that. But the emotional aspect is equally clear that disabling strokes are the ones we really want to prevent. And there certainly is a plausible mechanism, which is that these filters, they all pass small debris. The filter, it's not occlusive. And so small debris is always going to get through. The goal is to catch the big debris, which are the ones that cause the big strokes. And so I think it is very plausible that would be where the signal is. And maybe we're just barking up the wrong tree trying to prevent all the strokes, and we should be focusing on disabling stroke. But it makes me, one of the things that surprised me is that, why wouldn't they change the endpoint for the other big trial to be in alignment with what they think, where the benefit is going to be. That, is a little bit odd. And as, the other part, if you look, in great detail at the paper from the protected TAVR trial, most of the strokes in the group that got embolic protection, most of the disabling strokes, put it that way, were either the device failed for one reason or another, it just couldn't be deployed, or the patient coded in the middle of the procedure, things like that, or it was in the one vessel that's not protected. And so it does, certainly look like it's doing something. But I think we just, given the number of TAVR procedures, given the device is not inexpensive, it's about a $3,000 device to use. And, again, you can do the math at a hospital the size of Morristown or the hospital the size of St. Francis. It's a couple $1 million a year you could be spending on something that might not be doing anything. And so that is really where it kind of, you do a lot of soul searching on it. The problem is every time, if you didn't use it and you have a big stroke, you wonder what would have happened. So there's a lot, it's not a cut and dried situation, I think, and it's interesting to hear that, just 40 miles down the road, there's a big center, one of the very biggest in the United States, that is doing almost none. And then here, 40 miles away, they're doing it in the vast majority. If they got an appropriate anatomy where we can put it in, we use it because we don't think it's harmful. But again, it is a real challenge for all the centers. And I will say that nationally, the data are that trial didn't move the needle. I mean, there were 15% of people in the United States are getting protected before the protected TAVR trial was released, and it's really staying exactly exactly there. It sort of reinforced everybody's belief. The ones who were using it said, oh, it's preventing these disabling strokes, even if it's not statistically valid. The ones who were not using it said, I trust the study statisticians, and I'm going to continue to go, and we wait, and we wait for other devices. Again, that's the other, the other thing. I don't know. I mean, Andy, do you have any personal thoughts? I mean, you've been doing this for quite a while and have seen strokes like all of us.
No, it's a difficult problem. I wanted to ask, are you concerned about a non-specified endpoint being a very small number and reaching a conclusion or getting data that led to the conclusion saying, the recommendation that it should be used?
Yeah, I mean, well, I didn't love Dr. Kapadia's conclusion in his talk. I think George's one was better, where he changed should to could.
Well, he did. I'm sure he said that because he specifically said disabling stroke.
Yeah,
So
but even
where-
there, again, it still is uncertain.
Right.
And so I think there's room for uncertainty here, and it really does. But I think, I think as Dr. Petrosian said, to me, the key message is you either use it in almost everybody or you don't. Because the one thing that has been very clear is we're lousy at predicting them. They come out of the blue. You just don't know when a big piece of the aortic valve is going to embolize into a major cerebral vessel. And so pretending that we can pick and choose who we do it in is probably, we're just fooling ourselves, and is likely to make a mistake one way or the other.
One of the problems with the trials is I think that a lot of patients that are really needed were not included in the study.
That's possible.
And at the end, we want to enroll fast, and everybody get there, and then you have a low-risk patient with perfect arch, not a lot of calcium on the valve. This is low risk of stroke. On the other end, you have the patient that like valve and valve, calcified aorta, name it, all the risk factor, and then you don't have the anatomy. You cannot put it in. The frustration for me is in patient I want it. It's the anatomy on the carotid and then subclavian is terrible. So it's like and this is the one that stroke. So.
No, I think, and it's, I think it speaks to the need for other devices that will, again, there are devices that are being developed and being, in testing or in very early phase testing that are more of a kind of like a screen that goes across all of the major arch vessels. So it will protect, in theory, all the vessels, not leave one unprotected. On the other hand, those devices will just deflect all of the debris down into the legs and into the kidneys and other places. And so they don't catch the debris. So lots to learn, I think, with stroke. Let's switch over to talking a little bit about moderate aortic stenosis, or even asymptomatic aortic stenosis, which you didn't have a chance to cover. So, was there a question from the
Yeah, there was
audience?
a question
I'm
from
sorry.
the audience, like, do we, the question was, do we do cerebral protection for all TAVRs? And the question is yes. If the anatomy is amenable, we do use a sentinel cerebral protection device.
Although I would point out that, again, in some patients, the one thing we don't do is struggle a lot, right? If the anatomy is, a little bit dicey, and it's hard to get that second filter up into the left common carotid, a lot of times we'll say, the enemy of, good is perfect, because sometimes you can cause more harm than good there, and so we will stop and just protect the innominate, give one side of the brain as much protection as we can without hurting the other side. So I think we are we're enthusiastic, we use the device, but we don't sort of abuse the device, I guess I would say.
I mean, can I ask you, the panel, a question? So I mean, one of the issues anatomically I see with this device is that we're partially coming through an anatomy which does connect to the cerebral circulation, right? And, you mentioned about the mesh which lets some things through, but, we've seen from other, including, looking at these filters and other studies that actually we shear off stuff even when we don't think we're shearing things off. So I
Yeah.
think, I think a different design definitely would at least put at ease some of those questions.
I think, no question is that, I mean, when you look at the device and you see, again, every single case that you put it in, you get something, right? I mean, you never don't catch something. So that's what, I mean, that's what led to the approval. It's what convinces a lot of people they ought to use it in a lot of patients, but, you don't see what you cause, that doesn't end up in the basket, things that might end up in the head but not in the basket, so.
Cardiac cath data of MRIs after, any type of angiography, shows a shower. So it's, it's a concern.
Yeah, no, and it's, and again, what we didn't talk about at all, we were talking about stroke. George mentioned just very briefly in passing, is the idea of, dementia and other things late developing here. And there is data, and again, I would be remiss to point out, there is data suggesting that patients who have more of these silent infarcts that you can pick up on MRI do have a higher risk long-term of developing dementia. But none of the studies with embolic protection have shown improved neurocognitive function so far. So again, it's a very attractive theory. We have easy-to-use devices, but the evidence that they benefit is a little bit lacking.
I think this is a great study on the emotions of doctors.
It sucks to cause a stroke. I mean, nobody wants to go into a procedure and cause a stroke. Let's switch gears now and talk about sort of this, the future, and talk about moderate aortic stenosis and asymptomatic aortic stenosis. And maybe we should let Philippe, just because you didn't get to show it in your slide, just give us like a 1 or 2 minute about the early TAVR trial.
Before I would say, I was glad to see that you present 2 cases of moderate AS treated with TAVR. You had ahead of your time. So that's great. So mixed. Exactly, mixed. So the early TAVR trial is a completed enrollment. So it's targeting patient with severe AS, but with no symptoms at all after a negative stress test and normal EF. So there's a lot of patients that we see in the office, peak velocity 4.5 or 4.2, AV 8.9, and they feel totally fine. So, and we did a negative stress, we did a stress test that was totally negative. So this is very exciting. We have up to almost 1,000 patients randomized to TAVR with SAPIEN 3 device versus clinical surveillance. We're going to have 10 years follow-up of those patients. The study is completed, and hopefully we can have the data in around 12 to 18 months, depending on the follow-up. Every patient will have 2 years follow-up. We're going to have follow-up echo, CT scan, and biomarker. So I think that would be really an interesting study. And we already have 2 small randomized trials with surgery, around 150 patients each, that made New England in circulation, and that show in critical AS, these patients had a peak velocity of 5 actually with no stress test. And the other one was 4.5 with no stress test. That showed that those patients should have surgery actually. But so patient around 65 years old with bicuspid and a mechanical valve was implanted. So I think there's a lot of momentum. I think for patient with peak velocity above 4.5, I think we should intervene based on the surgical literature. But there's still unknown about the patient between 4 and 4.5 with negative stress test, with negative biomarker. What should we do? So I think we're going to learn a lot about the crossover rate, meaning when you have no symptom and negative stress test, how do you land in the symptomatic zone? And I think that's going to be the answer. Are you crash and burning at 6 months, or are you surfing for 4 years? So I think there's different phenotype of severe AS and AS in general, and who's resilient enough or not, but that will be very interesting. So that's early TAVR.
Yeah, I mean, I think it's a fascinating, study, and I'm glad we had Dr. Genero here to talk about it, because he's the one who, really kicked this whole thing off on the TAVR side. So let me ask Dr. DeMeo. So if you have a patient come in, to see you who's, 50 years old, feels totally fine, but has severe aortic stenosis, bicuspid valve, presumably in those circumstances, how do you deal with that kind of a patient these days?
Well, I think that if they do in fact have severe aortic stenosis, so the surgical literature would have a valve area of less than 1 or a peak velocity of greater than 4.5. That's a indication for surgery independent of patient symptomatology. You know, when you talk about different phenotypes, I think that's true. There is a certain subset of patients that seem to tolerate disease that other people won't. Often they have a lot of other they have a lot of other things going for them, which allows them to tolerate it. Or there's a subset of patients who, because their baseline exercise capacity might be so low because of, say, knee problems or other physical comorbidities that limit them, they can't really stress themselves enough to feel symptoms. And so for the surgical literature, if they have severe AS, we generally recommend surgery, period. I mean, I think the question of moderate AS is much more interesting. And I've found in my practice that if you have mixed AS and AI, I think those patients become much more symptomatic more quickly, and the pathophysiology really makes sense in that case. But a true moderate AS who's asymptomatic, I would not offer that patient surgery,
Yeah.
usually. Yeah.
The moderate one is, again, is a huge controversy, right?
Yeah.
Because as Dr. Jenner presented, I mean, the data are, unquestioned at this point that, moderate aortic stenosis for whatever reason has a very adverse prognosis, associated with it. But the question really is the valve what's killing these people, or is it the other things that come with moderate aortic stenosis that lead you to have an echo in the first place? Because remember, these patients who are being found to have aortic stenosis, they're not, we're not out there with an echo machine running around doing surveillance. And I am actually, because we're doing a study of this, but most people are not looking around for asymptomatic patients here. So some reason, they came forward, had an echocardiogram, were found to have moderate aortic stenosis among whatever else they had for it. So let's, I don't know, I think we should have a vote on the panel as to how many people think. So what's the endpoint, by the way, of the moderate AS trial?
Yeah, so it's very controversial, but the endpoint initially was death, stroke, and unplanned hospitalization for heart failure. Now we look. I mean, we're in the process of harmonizing the endpoint with other studies. I think we're going to land somewhere to death, unplanned hospitalization for heart failure, or unplanned AVR, unplanned urgent AVR. So there's a lot of patients, when I talk about how do you crash and burn, or do you a lot of patients with moderate AS come 2-3 times in the hospital, and it's hard sometimes to look at them and don't do anything, especially when they borderline, 1.1 and so on. So, COAPT went drastically because the crossover wasn't allowed for 2 years. They came 3 times in the hospital, they died from pneumonia the 4th time. So it's hard not to allow crossover for patients that need it. So, that's why the endpoint will probably death, unplanned hospitalization for heart failure, or unplanned AVR. Yeah.
So let me ask,
At 2
make
years.
a really controversial question here for the panel, and then we'll finish because then we have to have Dr. Khan come to give a really fascinating talk. The question is going to be, so let's say Philippe's trial is positive. It shows a benefit for that endpoint. Again, mortality, heart failure hospitalization, or unplanned AVR, right?
Urgent unplanned
Or
AVR.
urgent unplanned AVR. They're getting kind of sick, and they need to have it, it's symptomatic, very severely symptomatic in some way for that. But not a mortality, but it's not really driven by a mortality difference. A mortality difference is, a very minor trend or not at all. So let's go down the line here, start with Dr. Berkey, and say, if that trial is positive, would you, would that modify your practice to where you're, these kind of patients who would qualify with moderate AS and symptoms or signs of the heart getting damaged, would you push for TAVR in that kind of a patient? So, Andy?
Yeah, I think so. Besides kind of the triad of cardinal symptoms, chest pain, shortness of breath, or syncope, we have to add Dr. Henry's favorite criteria that a lot of patients, will say that, if you ask them very carefully, if they're doing as much, if they take naps in the afternoon or after a meal. So, I think that, there's a, patient side of symptomatic that a lot of these moderate AS patients really are, number one. Number two, if you start looking for objective criteria, if you start putting people on treadmills and doing stress echoes, you see things that, you aren't hearing about otherwise. So, yeah, I think that there would be enough information to say that, that the person has aortic stenosis, and it's not like 1 minute, if your valve area is 1.01, you're going to have no problem and be asymptomatic. But if the next echo, it's 0.99, you got to go. So I think it's, you have to treat patients differently, and I think you have to look for more information. And yeah, if it's a positive study, I think that we'll be offering the treatment.
Dr. Chung, do you agree?
I think overall, yes, it's a very mixed bag of patients. You have a wide spectrum, closer to the mild and closer to the severe range, and the patients are just a whole lot of varieties of patients. But I think symptoms and quality of life are definitely important, whether or not you have a hard endpoint. So I think I would agree.
Dr. DeMayo, do you agree as well?
Yeah, I would say that if you can show that it reduces hospitalization or improves CHF outcomes, then they should be offered TAVR or perhaps even low-risk surgical AVR as well.
Heaven forbid.
Which would also be in the algorithm potentially. Yeah.
I think so.
Yeah.
Let me ask Omar a slightly different question. Spare you this one. So you're the imager sitting on this panel.
Yeah.
What things do you think we might be able to learn from imaging to help us make the choice? Again, we don't know. We're going to be looking in great detail.
Yeah,
but what
so-
things are you optimistic about with imaging?
So I'll touch on the first question as well.
Okay.
I would say yes, and I completely agree with Andy. I mean, what we learned from, I did most of the stress tests for early TAVR when I was at Columbia, and patient stories are very confusing, right? You need an objective test, and besides, the things we look at, which are the EKG, drop in blood pressure, drop in EF, which you have to look at from the stress echo, you look at the patient. And sometimes they insist they're asymptomatic, but they look horrible once they get on the treadmill, right? They look really symptomatic. And that's something I record in my reports. So I think that's extremely important. In terms of the imaging, I think some of what we're discussing with the stress test is also the symptoms, but I think that will be related to cardiac damage, which is what Philippe is studying in the Progress AS trial. And I think there's further we can go with that afterwards, and there are also parallel studies of what else can we look at. Is it, Philippe's scheme is based on a lot of factors, but can we look at things like fibrosis on cardiac MRI? Are there other metrics we can look at which really predict those patients with a confusing story who actually know they're going to have a poor prognosis or symptoms?
I mean, I'm personally pretty optimistic about that, that line of thinking, that there's going to be things that we can, there are going to be patients who really benefit, and hopefully some combination of imaging and biomarkers will help us to figure out who they are, because, it is a mixed bag of people whose hearts are bad, but the valve isn't bad, patients whose valve is bad and the heart is a little bad, all those things. And so we really look forward to these wonderful trials that Philippe is doing to give us some, answers to difficult questions, and see if we can further expand the patients we benefit with these procedures, both surgical and transcatheter. I think in the interest of time, we need to move on to the next talk, and I'll bring Dr. Henry back up to do the introduction. Thanks very much.